In medicine, doctors often speak of getting the right dose of medicine or of treatment. But just what is the correct dose? In modern medicine, how much overtreating or overprescribing actually happens? Joining us now to help answer those questions, Dr. Danielle Martin, family physician at Women's College Hospital here in Toronto. Carol Kushner, author and health policy analyst. Shalom Globerman, president of the Patients Association of Canada. And we welcome back to the table Dr. Doug Weir, president of the Ontario Medical Association. It's good to have you three back to our studio as well. We want to remind everybody that we got a Twitter chat going on right now. Our producer, Daniel Kitts, is taking your tweets, hashtag AgendaTVO. So if you'd like to weigh in on the issues that we're talking about tonight, we look forward to hearing your feedback. Let's just start where Dr. Weir and I finished up, which is to talk about this annual checkup that is now going away. You've done these in the past, right?
I've done a lot of them.
You've done a lot of them.
Yeah.
Are they valuable?
It appears not.
But when you did them, did you think they were?
No, and we've actually known this for quite a long time, that there's no evidence to support the notion of an annual health examination. And Ontario is late to the game. There are many other provinces that haven't funded an annual health exam for quite some time. There is, of course, evidence to support certain maneuvers that we often do in an annual health exam. So, for example, I did one this morning before I came here, and I always make a point of making sure a person's immunizations are up to date. Well, making sure everyone's got a tetanus shot every 10 years or has their flu shot, that's an evidence-based thing. The pap smear or the mammogram or the discussion about vitamin D or exercise or smoking cessation, certain interventions that we often do as part of an annual health exam have great evidence to support them. But the idea of bringing you in once a year when you feel perfectly well and looking in your ears and looking in your throat and listening to your chest when you feel absolutely fine is not an evidence-based way to spend our time, and therefore not an evidence-based way to spend our money. And I think that that's a really important part of this discussion.
From a health policy analysis type of look at it, where are you on this?
Oh, I welcome it, because really we're moving towards measuring what's appropriate. Trying to individualize care so that patients get what they need rather than subjecting them to many, many maneuvers that are inappropriate, wasteful of money, and potentially exposing them to undue risks.
Shalom Globerman, you're here representing the patients. What do the patients think about losing that annual?
Well, one of the things that they talk about in doing this is to actually talk to the patient for a while, right? So some of the time we used in developing a relationship with a doctor, which is something that I think is very important. I think that patients developing better relations with doctors is I think, a big part of this. So we're very much in favor of this as well.
Really? Because I would have thought that... Listen, I don't know, I haven't done a survey on this, but my hunch is there are patients out there who like what they think is the emotional security that comes with knowing that there's going to be an annual exam that will be checking a whole bunch of stuff, even if it's not all that helpful.
Well, but it's not checking just all that stuff. It's actually developing a relationship with the doctor. If the doctor can, in fact, personalize the interview and personalize the examination so that it fits the patient and the needs of the patient at that time, that would be much better than having a check like a car would have.
So you can actually do more and better with less.
I think so. I think that having that spending time with someone and getting to know them a little bit and getting to know what their lives are like and where they are with things is really very important for the doctor and for the patient. And in fact will allow the doctor to see things that might be wrong with the patient that are not done by instrumental methods.
Dr. Martin, can I go back at you on this one more time here? Mm-hmm. Because I want to know if in your experience you picked up more things that were of concern to a patient in terms of their health through that annual exam, or did you find more false positives and create more stress, and therefore in the final analysis it wasn't worth it at the end of the day?
Well, of course the answer is both, right? And that is one of the things that makes it really tricky, is that everyone has a story of someone they knew who had something picked up on a routine visit that might not have been picked up for some time had it not been for that routine visit. But on a population level, it's not a good idea. That's not how you run a healthcare system, right? You need to look at what there is an evidence-based support doing for everyone all the time. And so I would, as Sholem says, I would much rather spend my time rather than doing a whole bunch of stuff that I know is unlikely to be useful for someone, talking to the person and determining what is it that's going on in their life right now, or what is it about their family history, or what is it about their personal history that puts them at risk, and working around that more personalized view than feeling that there's a checklist of things that I need to get done in order to be able to say I've done an annual health examination.
But you're thinking, Carol, if I can put it this way, in a broad systemic way over a whole $48 billion healthcare system. The patient doesn't think of it that way. The patient thinks of it as my one-on-one interaction with my doctor.
That's right, and they're still going to get that. There's still an expectation that patients will meet with their doctors once a year and discuss an individualized plan for investigation of symptoms or signs or of treatments, a review of their medications. There are many, many useful things that could be done in the context of that annual visit, including the doctor's reassurance that subjecting them to a whole battery of tests was really not very useful for them.
Doug Weir, medical testing can be bad for your health?
It can be, and I think just I want to pick up on a point is I think there's going to be a change, right? So some people who've been having physical exams every year for the last 30 years, when they come in this time and they say, we're not going to do that, we're going to have to explain to them why we're doing things differently, and we have to explain to them the fact that there's risk and benefits to this. So sometimes doing a test leads to more tests, and those more tests have their own risks associated with it. And I think we're going to have to explain that to patients so that patients understand the rationale behind what we're doing, and that at the end of the day, this is going to be better for them.
Okay, but you gave me an example in our last segment about somebody who comes in, no symptoms of any kind whatsoever, picked up by the annual checkup, but then 2 months later, back pain, they discover it's a tumor.
Yeah.
Presumably, blood tests would pick up things like that as well.
Well, no, so this person is somebody who had all the blood tests, and it's because that's, I think we've come to the idea that somehow if we do all of these tests, we're going to pick up something. But the reality is oftentimes we don't. It's not the right time, and that what's going to pick it up is the fact that they develop some sort of symptom. And that I think it's important when people get these symptoms, they go in and they get the appropriate investigations at that time. But I think there's a kind of false reassurance sometimes that by just going in and having all of this battery of tests done, that if it's all clear, that somehow you're in perfect health, because something a month or 2 months down the lines could actually show up that probably was brewing but didn't show up on any of the tests.
Would you echo that you get your blood work done and you get the all clear and you think you're fine?
One of the things that's been true about medicine for the last 20 years is that there's a whole question inside this about instrumental medicine. That instrumental medicine was very good for picking up things that you get as a result of testing and leaves out the interpersonal relationship. I think that as the morbidity of the population shifts from acute infectious diseases to chronic diseases, the person and the person's lifestyle, what the person eats, what the person's environment is, what their psychological makeup are, all have much more to do with the coming of a disease and the ongoing of a disease than these tests. So the idea of going from an instrumental kind of medicine to a more human and individualized kind of medicine really does come from that shift in morbidity. And I think that that's one of the things that this shift shows, that the studies show that in fact people aren't benefiting from old-style instrumental medicine, and they need a new kind of medicine, which is individualized and relationship-based.
My hunch, Carol, is that people will say, I'm with you as long as there are health reasons behind this. But if it's all about the government trying to save $20 million, for other reasons, they're not with you.
Right, and clearly this is not just about saving money, although I think some money will be saved as a result of these changes, but it also has to do with protecting your health, not exposing you to unnecessary risks. When false positives occur through a battery of tests that were not warranted, you may be subjected to biopsies, other invasive procedures that you could have avoided. So really, the conversation needs to still reassure patients that they will always have access to care based on their signs and symptoms and their personal concerns. But that conducting a huge battery of tests is not likely going to be useful to them.
Let me do one follow-up here, and I'm going to, Danielle Martin, let me do it with you. Dr. Weir told us in the previous interview that pap smears are going to be done, for example, I think every 3 years. They used to be done every year.
Right.
The guy whose name I will say at the end of our discussion here, Daniel Kitts, who's producing this program, talked to a patient. She has a history of cancer in her family. She is concerned that under the new rules, getting this pap smear once every 3 years instead of annually, they'll miss something. Is she right to be concerned?
I mean, I think people are always right to ask questions, and I have this conversation with women in my practice all the time because, of course, we have seen this move over time as we have come to understand more and more about cervical cancer, that in fact doing an annual pap smear doesn't save lives. Cervical cancer on average takes up to 10 years to develop, and so we weren't saving any additional lives as a result of doing them manually. We were picking up false positives or potentially concerning cells, which the body actually heals on its own if left alone. But we were doing pap tests so frequently that we were picking women up in those stages of inflammation and therefore exposing them to more invasive investigations as a result. And so we have come to learn that, in fact, we now believe that the ideal time interval is 3 years. Only a couple of years ago, we thought it was maybe 2 years. And it may be that our understanding of that will evolve over time. And so I think it's important that we shouldn't make categorical statements to patients about any of this. If she's got a family history, for example, I understand why she would be concerned. We would want to talk about that in a personalized health review and what it is that's concerning to her, talk about her risk factors for cervical cancer.
It sounds like you have an education job to do as well here to tell patients.
A huge education job. And what's interesting, I think, is that, this offers me an opportunity and my colleagues an opportunity to change our practice in a way that actually is consistent with the evidence. I mean, there was no law that said we had to give out annual health examinations, simply that the government was paying us to do them if we chose to do them. And so even though we as family doctors, as a community, all knew that the evidence didn't support it, we continue to do it anyway. Why? Because there's some inertia, right? That the patients expect it, we're sort of used to doing it, you're getting paid to do it, you're in a habit, you keep doing it every year.
No, but the math suggests that if you do it every year instead of every 3 years, you'll catch more cancers, wouldn't you?
Well, you may catch more cancers. Unclear whether you'll catch them at an earlier stage necessarily. Unclear whether any lives will be saved as a result. So, in terms of when the treatment, when you diagnose something sooner, the question is always, would it have made any difference if we had diagnosed this any
and I think
later?
the important point there is actually, in fact, there aren't more lives saved. In other
Right.
words, the evidence is that if you do them every 3 years versus every year, that at the end of if you follow in terms of outcomes, the outcomes are the same. There aren't more people surviving who were picked up on those annual ones than the ones who were picked up every 3 years. And I think the other part is that when you do them more frequently, what you end up getting is you get more women who are exposed, who don't have cancer, to biopsies and things like that, which have their own risks in terms of affecting their reproductive health further down the line. So what we're really doing is really in the patient's best interest by avoiding other risky kind of procedures, and the outcomes are going to be exactly the same.
I think that the big thing here is that in the past year, it's become very wide public knowledge. Like the New York Times has said that cancer is a chronic disease. It's not an acute disease. So the idea that used to be, and we still, most of us think that getting cancer or being diagnosed with cancer is the big C and you're going to die. Well, it's not true. So it turns out that our methods of diagnosing cancer are much better. We find it much earlier. And the risk of dying from many of these cancers is much lower. So it turns out historically that we've been overtreating some of cancer. We've been overtreating prostate cancer and breast cancer. And now we have to learn how to treat it properly. And learning to do that is to do less testing, is to actually look at the disease and see what the causes are.
Except, Carol, we've had a war on cancer for 50 years. You have a population that is that has been educated to expect a certain approach, right? And now you're basically saying to people, forget what we told you for the last half century. We're doing it a new way, right?
Yes.
How hard is that?
It's always hard to confront beliefs and cultural expectations. It's hard for everybody to change, but that's what we have to do if we're going to manage healthcare properly. And if patients want to be protected by being assured that they're going to get evidence-based medicine as opposed to what they thought was a good idea, that's a good thing.
I don't know that people want that. What do you think?
Well, do people want that? Nobody wants to be told that what they've been getting for the last 30 years is, in fact, inappropriate care and expose them to all kinds of risks. That's the truth. So the
Can we handle the truth?
Well, it's a very good question. I mean, that might be a question better posed to Sholem, but I would say that most people trust their doctors and want to have an honest, open conversation about these changes. They won't necessarily like to hear what they're going to hear, but I think they'll come to accept it in time. If they trust their doctor, they will believe what the doctor says.
I agree. People do trust their doctors, and every poll that I've seen suggests that. Yes. So how's that next checkup going to go when the patient walks in there and says, okay, wait a sec, you've been telling me it's been this way for the last 25 years and now it's going to be this way?
I don't think that it's ever been that strong. I think that the annual checkup has been becoming less rigorous over the years. I think that also some doctors haven't practiced actually doing the annual checkup every year, but have let it happen every 2 years and every 3 years, depending upon the health of the patient. So the actual practice is different than the payment fees. And I think that, so this change has been happening over years. It's not, we understand, for example, many years ago, nobody thought about heart disease. They only knew about heart attacks. Now we understand that heart disease is slowly progressing. It's those kinds of things that have been shifting. So the general public also has had a shifting view of it. It's not as if everybody expects this kind of rigorous instrumental medicine to be applied to them every time. And in fact, I think that people will be quite grateful to have time to talk to their doctor about their life situation and the kinds of things that they're doing for their health. I think that those changes are all for the positive. And
let me, Dr. Weir, close the loop on this. You mentioned that with the end of the annual exam, the annual checkup, in the way that it has been done, taxpayer saves $20 million. How about going from once every 3 years as opposed to an annual pap smear test? Any idea what that would save?
I can't tell you what the number is or what it's going to say, but what it will allow is for doctors to do other things. In other words, if you're not doing that, you're going to be doing something else.
More relevant and
more relevant, yeah, and more evidence-based. So I think in that way, there's going to be savings in the fact that instead of doing it every year, it's going to be every 3 years. Unfortunately, I can't tell you the number off the top of my head.
Okay.
There's a recent article in the New England Journal of Medicine that says that patient experience improves outcomes. So the patient experience of an annual visit with the doctor where you're actually talking to the doctor and not just being exposed to a series of tests would probably improve outcomes as well.
The other thing to remember, my experience, I've been having an annual physical for many years. They've never found anything on any of them. So I don't think, for me personally, I would say, well, you know, it makes sense. I've been doing these for a long time. You've never found anything. And I think a lot of people are going to have that experience. That they will realize I've been going to these things and nothing ever came of it. And that it's not going to be a total shock to them when they're told that the evidence shows that this isn't that helpful.
But let me pick up on the talking angle here, because, and I don't mean to stereotype here, but I can do the math. You're older than she is. You were taught how to do medicine a certain way. You were taught how to do medicine a certain way. You were taught, I'm guessing in your day, to be less touchy-feely about it than you were. You were taught to be a better listener than he was. You're now all going to have to be better listeners. Are doctors ready to do this?
Yes, I think so. I mean, I think that the complaint that you tend to hear from doctors is not so much that they don't want to listen to their patients, it's that they feel caught on a treadmill that they can't get off of, and that the pressures of practice with a lineup of patients that they can't seem to kind of get on top of, and the mounds of paperwork that they can't seem to get to the bottom of, make it really difficult to give people the time and attention that they wish they could. And so I don't think it's a question of having to retrain. I mean, listening actually is the original doctor's tool. It's, you know, it's not the tool of my generation. It was the tool of many, many generations before either of us, when that was all you had. And I think there was this evolution of medicine that you've heard Sholem describe over generations. With the more fancy machines we've had and the more fancy tests we've had, the more those have almost become a replacement for good old-fashioned listening to what a person had to say. And now we're beginning to realize that actually there is no replacement for that. And perhaps we need to spend a little bit less time on the technology aspect of things and a little bit more time looking at the whole human being sitting in front of us.
What's your confidence level about, and I don't mean to be stereotypical about this, but the anecdotal evidence suggests that if you've been a doctor for 40 or 50 years, you might be not quite as good a listener as somebody who is trained more recently in the touchy-feely arts of listening.
I'm sure that that's true. I think that instrumental medicine didn't come in 50 years ago. I mean, it's come in slowly over time, and it's become more serious since. So I think that some doctors obviously won't be able to do this very well and will have to learn. But I think most doctors are it's exactly right. It's that people would like to have more time. They have a 10-minute span or a 15-minute span that they have to do their work in. Now they'll have more time to talk. And I think that will be used. I think that largely it'll be used.
I actually think older physicians want to be able to listen to their patients, and we're trained to do that. I can tell you when I was in medical school, there was a huge emphasis on interviewing and listening skills. And I think actually, and this is what was brought up, is that over time with more technology, there is more reliance on blood tests that weren't around when I was in medical school. Yeah. CAT scans weren't there, MRIs weren't there. A lot of tests that physicians rely very heavily on now weren't there. It was mainly the physical exam and listening to patients. So I think actually older physicians are going to be excellent at this. In fact, one of the pushback on this when it first was announced was that physicians said, but this is a time when I see patients on an annual basis that I get to talk to them. And I think they had the misunderstanding that somehow the whole thing was going to be scrapped and they wouldn't see them anymore. So I think that the key part of this, why I think people keep doing these annual exams, is the fact that it does give them that chance to sit down and talk to them, which is different than when someone comes in for a sore throat or something like that, which is much more, you quickly look at them and they're out the door.
Okay, but Carol, I am going to stereotype here now.
Okay.
The older male doctor, once upon a time, who, when the older female patient came to him and he was just completely unprepared to talk about menopause and the onset of it with an older female patient. I mean, that's a pretty typical example, isn't it?
That's an interesting example, but it's not typical of the care I've received. But let's just say that every individual has strengths and weaknesses, and communication is a quality that varies within a profession, just like it does in the population. My experience of medicine, of family doctors, is that they've been excellent communicators. They haven't always had time to listen. And one of the issues is that patients aren't trained to mention their most pressing problem first. So I remember seeing some research that suggested that physicians interrupt patients after only 18 seconds of the patient's narrative, this is old research. But it suggests that if that patient wasn't clever enough to know that the most pressing symptom needed to be mentioned first, the doctor might miss it.
So you better not bury the lead.
So that's right, don't bury the lead. It's a journalistic lesson.
We learned that right away in J School. Okay, Daniel Martin, let me get to you on this, because I think 5 or 10 minutes ago you gave us kind of a bit of a laundry list of things that medicine is grappling with. And I want to bring up one of them right now. This is a quote by David Friedman out of Discover magazine from a couple of years ago. And Control Room, let's bring this up and we'll get a question coming out of this. Take this straightforward and critical question. Can vitamin D supplements lower the risk of breast, colon, and other cancers? Yes, by as much as 75%. Several well-publicized studies have concluded over the past decade. No, not at all. Several other equally well-publicized studies have concluded. In 2008 alone, around 380 published research articles addressed the link between vitamin D and cancer in one way or another. The ocean of data on the topic is vast, swelling, and teeming with sharp contradictions. Okay, what do we do about this?
That's a big problem. And so, I try to remember for myself to be a little humble about the recommendations I make to patients, because you never know what's going to come back to bite you 20 years from now and turns out to be exactly the wrong advice. All we can do is our best to stay on top of the emerging evidence. And all we can say to patients is, look, based on what we know right now, this seems to be the case. So vitamin D is a great example because there's been so much publicity around it. First it was going to cure everything, and then it was going to cure nothing, and then it turned out that everyone was deficient in it, and then we delisted testing for it because, in fact, and so this is a great example. The Ontario government no longer pays to check people's vitamin D levels in their blood because it's a useless test, because we know that the vast majority of the Canadian population is deficient in vitamin D in the winter months. All of us should probably be taking a supplement, whether it's going to prevent you from getting cancer or not. It's good for your bones, it's good for other stuff. It tends, if taken in the right quantity, it tends to be one of those might help, can't hurt kinds of interventions. Why are we spending millions and millions of dollars testing people's blood levels of vitamin D? So, but I think the issue you raise is this broader question of, given the amount of emerging evidence all the time, particularly for those of us practicing in generalist fields in medicine, is the advice that we give to people always going to be right? And the answer is, of course not. No, we're going to learn, all of us together, as we move through our careers.
This, Doug Weir, is insane because, you know, we've been told for 25 years, keep your kids out of the sun, or if they have to be, at least put sunscreen on them. And now we're all vitamin D deficient. We're being told, actually, let them go out and play in the sun for a little while. It's okay. What's a patient supposed to do?
Well, I think we have to take the balance of the evidence, and I think we're still advocating for sunscreen because that's still a huge risk factor in terms of skin cancer. And I think vitamin D is because we live in a northern climate, we just don't get enough sun. So I think what we have to say, that would be the advice today, and maybe in 10 years it's going to be different. I think we just have to be practical about it, that doctors don't always have the answer, because it's a constantly evolving and changing landscape. And we have to be able to be nimble so that when we have the evidence, and I'm just going to go back to the personal health review, the evidence has been mounting for like 30 years. I don't think there's a lot of evidence to the contrary. I think at some point we have to make a move and do something about it. And that's the same, I think, when we look at all the other things that we do. We have to see when we look at a number of different studies, is it moving in one direction or the other? And that's what the advice we have to give to our patients.
You see, I think the thing that's been changing is that our healthcare system and the scientific background for it was based on acute infectious diseases. Those diseases had a clear cause, a clear course, and a clear kind of vaccine that would stop it from happening. And the picture was that all disease would be like that. So they talk about things like conquering cancer. But cancer isn't a disease like that. Nobody's going to conquer it. The picture of it is it's not a natural kind. It's not like a plant or a flower or an animal.
And it's 200 different things anyway.
That's right. And it's 200 different things anyway. And there are different factors, including lifestyle, genetic makeup, and all kinds of things like supplements. And the same thing is true for our general health, that we're not going to have any one answer. So some of these things work for some things, and some of them work for others. So the idea that there are very clear and precise instructions that people can be given in order to lead a healthy life is wrong. And that's why this notion of relationship and interaction and what counts for one person and what counts for another person is so important. And it's why this shift is so important, that we don't think about it as the definitive answer and looking for that all the time.
But Carol, this is what's going to be difficult, because what if in 20 years the future Minister of Health meets with the future head of the Ontario Medical Association and discovers, you know what, we really should have, there's new evidence in, and we should have been given pap smears every year instead of every 3 years like we thought 20 years ago. And here we go around in circles.
Then we will change again, because the quality of the evidence really does matter. And sometimes, the conflicting evidence about vitamin D may come down to the quality of the research that was done to produce that evidence. And this is an important point, because obviously the manufacturers of vitamin D medications would have an interest, for example, in promoting the idea that people should take vitamin D supplements. Perhaps less disinterested researchers would design a study that was less likely to be biased towards that answer, but might still produce it, which would tend to support the idea of vitamin D. It's not just the quality of the research, but who funds it and how it might be tainted to some degree.
What's your confidence level about how clean the research is that we're getting today on these issues?
Not good.
Not good, eh?
Not good. Not good. I think that there has been an enormous, particularly in the area of medications, there's been a lot of data hiding. The research is predominantly funded by the pharmaceutical industry. They have a vested interest in promoting the benefits of the products that they make. And they have a tendency not to publish negative results. So doctors are exposed to an overwhelmingly positive view of new medications, and that's a problem.
Of course, we also need these companies to come up with new inventions all the time, because
they're not doing so great at that these days.
Although I would also say that's changing. I mean, all of what Carol said is true, but we all know that now. I think physicians are much more aware of pharmaceutical research and in terms of biases and things that might be there, and people are looking at it with a much more critical eye. And so I have more confidence in it. If you think of the changes in terms of medical treatment, for example, if you just think of breast cancer, I mean, 30 years ago, radical mastectomies were everybody had them. Now it's totally different. And that's because of evidence and good research. And so I'm actually, over time, relatively optimistic that whatever happens, it will change. I'm confident of that. But eventually the bad news comes out. I mean, pharmaceutical companies may tend to want to emphasize the positive over the negative, but if there's a lot of negative out there, my experience is it comes out and we do something about it fairly quickly.
Dr. Martin, you wanted to circle back on a point.
Well, I just want to say that I think when we talk about this stuff, we have to be careful not to just talk about doing less. What we're talking about is appropriate care, right? And so there is a portion of the population in Ontario that has probably been getting too much health care, too many tests, too many drugs, too many doctor visits that aren't improving their health. We also have people in our population who are not getting enough, right? So Women's College Hospital, where I work, is involved, as are others, in a huge project to screen, going back to the pap smear, women who have been under-screened or never screened, which we have many, many, many of, even in just the GTA. New Canadians, people who face barriers to accessing healthcare because of mental illness, et cetera, who may never have had a pap smear in their lives. So you've got women who are getting them annually, who only need them 3 years, and you've got women who are never getting them. So it's not just about doing less, it's about looking at the population thoughtfully and saying, how do we balance this out so that everybody is getting the right amount? You know, it comes back to the thing that you said at the beginning. How do you get the right dose? And appropriateness is not always about giving less. Sometimes, for some people, it will actually amount to giving more.
You've told us who gets less but needs more. Who's getting more but actually needs less? What kind of demographic?
Well, I think it tends to be more middle class, upper middle class people. I see in my practice people who are really on the high end of the socioeconomic spectrum, whose companies pay for them to get these executive physicals. If the annual health exam is bad, the executive physical, in my personal opinion, is worse because the number of tests that are being done that are not grounded in evidence in some of those physicals is enormous, and then the number of false positives that then get referred back into the public system is enormous and clogs up the system with unnecessary stuff. So there's some of that going on for sure, and then there are many of us, myself included, who just get into the habit of doing things like having an annual health exam, and so probably if you're doing that, it turns out that maybe you've been already getting too much care.
So you won't do it this year?
No, I won't. And I probably haven't, but I think that certainly as a physician, I won't be doing it anymore for my patients. And what's good about this policy change is it's forcing me to get my practice in line with the evidence in a way that I wasn't doing before the policy change came about, so I welcome it.
Shalom, let's look at the overarching question then. As Danielle Martin's just described it, too many Ontarians getting too much health care they may not need, too many Ontarians getting not enough health care that they might need. So there's a balance that needs to be struck. How are we doing in this province at striking that balance?
We're very mixed. I mean, we have a population. Well, this is true in every healthcare system. It's not just the Ontario one. It's that people who have strong relations with their physician and who are middle class and who expect to be seen on time and expect to have certain kinds of things happen, they get that. And I think that there are large numbers of people who get significantly less. That's certainly true. But that's true in every healthcare system, and trying to fix that is a big job, and it's a job that's happened in some, but not in all healthcare systems. And certainly here in Canada, we have, I think that the biggest shame in our population is the healthcare and the treatment of Aboriginal people. I mean, it's quite obvious. It's not a secret.
Who fall outside the provincial responsibility, though.
Look, one of the things that's true about Canada is that the longevity of our population isn't all the same, right? There are the people who have mental illness tend to live much less long than people who don't. That people who are of Aboriginal background tend to live much less long than people who are white. So we have big, significant differences in health status in our population.
Carol Kushner, striking that balance, how are we doing?
Well, we've had evidence of variations, small area variations in the provision of services, various kinds of surgeries, for example, for a very long time. These variations suggest that some parts of the province provide a lot of care, a lot of one type of service, while other parts of the province provide less care. To follow up on that, because we can't say which is which, who's got the right rate, we need to do outcomes analysis to see whether that extra care makes a difference. When this has been done in the United States, it's pretty clear that people getting the most care are really not getting the best care, that the outcomes are virtually identical between the low-rate areas and the high-rate areas. By saying this, I don't mean to suggest that there aren't undertreated people in Ontario. There are. One of the most obvious examples are people with chronic pain who often report being undertreated for their problem, particularly in our nursing home system, just as an example. But there's a real obligation, if we're going to move towards more appropriate care, I think for us to look much more carefully at those small area variations and do some further investigation towards identifying the appropriate level of service.
Doug Weir, how are we doing on striking the balance?
Well, there's more work to be done, and there's always room for improvement. And one of the things I want to add is that part of our agreement with the government that we struck is that we're going to continue to review, and we have a long list in that agreement of other services that need to be reviewed.
Like?
Blood tests for diabetes, for example, bone mineral density testing. There's a long list of tests that really need to look at the evidence and see what kind of guidelines should be put in place. And so that's part of what's going to be happening over the next year that we're going to hopefully be looking at. And part of the agreement is to look at both the underuse and the overuse. So it's not just the overuse, but maybe there are some things that should be done more that aren't being done, and we need to find ways to encourage physicians to be doing them, or to encourage, because some of it is a education to the public to make sure that people are getting tests done that they're not getting done now, which was mentioned.
We need more Ottawa ankle rules, eh? You know what these are? The Ottawa ankle rules?
Yes,
No,
absolutely.
I don't know what they are.
Oh, and that's fine. The Premier talks about this all the time.
It's an evidence-based guideline that, when applied, successfully reduces the number of ankle injuries that require X-ray.
Oh, okay, yes.
And apparently the people who developed it are from Ottawa, Ontario, Canada. And they're all over the world now.
That's
right.
There's our little
That's right. It's a very good
teaching
news
moment
story.
for the day.
Okay.
Yeah. I want to find out whose job it is to kind of remedy all of this. I know the obvious answer is, it's frontline docs who have to resolve all this, but then we hear that these changes often happen as a result of negotiations with the Ministry of Health and Long-Term Care, and and this is such a vast system. You wonder how these things get resolved. So, any ideas on this?
We have very clear views about this. I mean,
Go
one
ahead.
of the things that we think is that because the nature of people's illness and people's health has changed, we think that patients and their families have to be far more involved in the healthcare system.
Involved means what?
Well, they have to be engaged in policy development and in thinking about these policies together with the providers. They have to be part of groups that redesign services. There are lots of examples of that. In emergency rooms, the vast majority of people aren't very sick, but the emergency room isn't trained to deal with people's anxiety at all. All that they deal with is whether you're sick enough to go into the emergency room. So there are lots of things where a patient's perspective and patient's view of these things would really make a difference, both in regularizing and in getting a better relationship with doctors and patients.
But if these things happen, if change happens because you're at, quote unquote, the table, are patients at the table now?
No, but they're coming to the table. So patients are beginning to come to the table. There are patient and family advocates in a number of hospitals in Ontario already. We're going to have the first conference of patient advocates in Toronto in April, that patients who are actually there thinking about and working with providers to find the best mix of services and policies.
They want you at everything, I guess, now, don't they?
They're beginning to want us. Yeah, they want us here at the agenda.
Well, you've always been welcome here. You know that.
Occasionally.
Danielle Martin, how about it? Whose job is it to fix this?
Oh, I mean, that's the million-dollar question, because we don't function in a healthcare system that has a top-down authority structure. So that even if the Minister of Health were to say, let it be so, it's not, there's no lever. I think it was Tony Blair who said when he went into office, he started pulling on the levers of power, and after a few months he realized they weren't connected to anything, right? That's our Minister of Health. I mean, you can't actually by decree make these things happen. And so I think actually, to give credit to the government and the OMA, this agreement that they have negotiated, I think is a really good first step. And I respect Sholom's view about bringing patients into the mix. But to finally have government and doctors sitting down together with a common goal of improving the healthcare system and increasing the appropriateness of care, instead of just, not that it was this simple, but arguing about money, which negotiations can tend to disintegrate into any labor negotiation. That's a really important first step. And I think the fact that there's a commitment on both sides to continue looking at evidence-based implementation across the system is a really positive move.
Would we want a healthcare system where the Minister of Health could simply say, pull this lever, I want this to happen, let it be said, now let it be done?
I remember it happened once.
When?
When Eleanor Kaplan stood up at a conference.
I remember this.
Yes, and she just
About
basically
Sudbury, right?
declared that C-section rates would decline in Ontario. I can't remember what her target was, but it was, I mean, it was like a fiat. Well, of course, we've seen C-section rates go up in Ontario, not down. So it's not very effective leadership to simply declare what shall happen. But it is very good to work within the context of an agreement that was supported by 4 out of 5 doctors in Ontario, which is extraordinary. So now that they've signed on to this, or 4 out of 5 of them have, there's an opportunity to test it. I don't know how this is going to be enforced. It will rely on the goodwill and the good sense of medical practitioners and patients alike.
There's 2 ways of looking at that, though, Doug Weir. One is that 80% buy-in is pretty good. The other is that there's 20% of doctors out there who, who did not buy in, and they're certainly capable of creating a lot of mischief, if I can put it that way.
Well, but I guess the hope is that they are going to be influenced by the 80%. And I guess, and the thing is, I would say, is I think when you have to go back to the original question, where does it come from? It comes from both, really. If you think about it, I'm going to use an example, which is a physician at Mount Sinai Hospital, Samir Sinha, who I think was on the panel last time I was here.
And it will be on this week as well.
And he was instrumental at a local level at his hospital in terms of making innovative changes in the care of elderly patients and frail elderly, keeping people out of emergency rooms, keeping people out of hospital. So that was at a local level. He then went and was asked by the Minister of Health to go around the province, talk to patients, the family of elderly patients, and various healthcare providers. And he came up with recommendations for the government on a senior strategy. Mm-hmm. And now that's working its way through the Ministry of Health, and there's going to be recommendations that are going to be implemented, and some of that's going to involve negotiations with the Ontario Medical Association.
He's made 169 recommendations, and they're looking at it now, and I think actually it's next week that he's on.
So that's, but that's an example of something that started very local, and him making innovations at a very local level, and now expanding it sort of province-wide. And so I think if you think about some of the things that are in our agreement now, some individual doctor somewhere had an idea that developed guidelines that then eventually get implemented in an agreement. So it's really, we need both. We need the on-the-ground physicians who are going to see areas they can change. If you think about it in terms of infections rates in hospital, oftentimes it's some innovative doctor in one hospital who comes up with a great idea and then it spreads to the rest of the province.
I've heard the great idea in that case is just washing your hands.
Mm-hmm. That's the key aspect, washing your hands.
And docs don't like doing that.
Well, it's everybody. I mean, if you look at it, it's the cleaning staff, it's the nursing staff, it's physicians. Everybody gets out of the habit. And that what we need to do is we all need to wash our hands more when we're in a hospital.
Sheldon Globerman, down to our last minute here. Are you satisfied things are moving in the right direction?
I think they're beginning to. I think that people are beginning to. The underlying change is starting to happen. People are starting to see that we have to move away from instrumental medicine. We have to start to relate to patients better. All of those things, yeah.
What do you think was the key driver in changing the message?
I think it's the overwhelming view that the kind of health and sickness that people have is changing, that it's not going to be discovered in this kind of instrumental way, that we really do have to understand what the other factors are and we have to relate to our patients.
Terrific. I want to thank all 4 of you for coming in today for a most engaging discussion about this issue. Danielle Martin from Women's College Hospital. Carol Kushner, the health policy analyst. What was that book that you wrote once upon a time?
Oh, Strong Medicine.
Strong Medicine was one. I think I read another one.
Second Opinion.
Second Opinion was the one I remember reading as well. Okay, Sheldon Globerman from the Patients Association of Canada and Doug Weir from the Ontario Medical Association. Thanks, everybody, very much.
Support Ontario's public television. Donate at tvo.org.